Hello everyone. We will talk today about cardiac examination. As we all know, cardiac examination is divided into general examination and local examination. The aim of general examination is to pick a cause or a result of the cardiac problem. This actually starts from the first look to the patient. If we have a patient, for example, a tall and thin one, we should suspect something like Marfan syndrome, which is linked with aortic disease. Also, if we have a patient with morbid obesity, we might expect the presence of metabolic syndrome, or if the patient is complaining of dyspnea, we should suspect heart failure with preserved ejection fraction. Also, the position of our patient in the bed might give a clue about the volume overload. Like this patient, if we have a patient with orthopnea, this might denote marked volume overload. Then start with a quick journey around our patient, starting from the hand towards the head and neck, then down to leg examination, then abdominal and chest examination. When we are looking to the hand, starting with the dorsum of the hand, we are searching for clubbing, like this one. Clubbing in cardiology is related to one of three categories: either cyanotic clubbing in patient with cyanotic heart disease, toxic clubbing in patient with endocarditis, or might be seen in a rare cardiac tumor which is called myxoma. Also, we are searching for signs of endocarditis, especially if our patient is presenting with fever, like splinter hemorrhage or osseous nodule, which is a painful nodule in the bulb of finger. Looking also for precipitating factors for heart failure, like anemia, signs of anemia varying from pallor to exaggerated finding like koilonychia or spawning of fingernail. Tremors, like in patient with hyperthyroidism, might be picked on dorsum of hand examination. Then shifting to the palm of hand, searching also for other signs for endocarditis, like Janeway spot, which is a painless spots on the palm of the hand. Palmar erythema, which might be seen in some systemic disease like systemic lupus or liver cirrhosis. Then step upward for radial pulse palpation. We are recommending or assessing the pulse for first thing is irregularities. If we have irregularity in the pulsation, this might be either occasional irregularities that could be seen in patient with extrasystole, or might be marked irregularities that's seen in patient with atrial fibrillation. We can differentiate both by comparing the rate of pulse at the radial artery and at the apex of the heart by auscultation. If there is a deficit between or a gap between the rate of radial and apical more than 10, this called significant pulse deficit, which seen in patient with atrial fibrillation. While in patient with extrasystole, this number will be less than 10. Then assessing the rate of heartbeat per minute by assessing simply the rate in 30 seconds, then multiply by 2 for the sake of time. Assessing pulse volume. To appreciate any abnormalities in the pulse, you should palpate a lot of normal person to become aware of the sensation of normal pulse volume, which is called average pulse volume. So then you should appreciate a small or large volume. Then checking the pulse in both sides simultaneously. Normally the pulsation is equal in both hands. What is the causes of unequal pulse? The most common cause is iatrogenic, actually, following radial puncture for cardiac catheterization or EPG sampling. The most dangerous cause is aortic dissection, which cause damping of the flow to the left subclavian artery, causing unequal pulse on both sides. this should be might be seen in about 1/3 of patients with aortic dissection, and this is life-saving diagnosis. Might be also caused by obstruction inside the artery itself, caused by atherosclerosis, or compression outside by a cervical rib. These are the causes of unequal pulse. Then assessing what is called the pulse character. If we have a patient, we are thinking is this pulse is normal or large volume, then we go for checking for water hammer pulse by baking the arm of the patient, like in this picture, and trying to palpate the brachial pulsation. If the brachial pulsation are transmitted across the muscle bulk to your fingers, then this should be a patient with a large pulse volume. So this is called water hammer pulse. What is the causes of water hammer pulse? A large hyperdynamic circulation, like in anemia, thyrotoxicosis, pregnancy, or pathological cardiac problem like aortic regurgitation. What are the other characters that might be picked or seen in patient pulsation? Pulsus alternans, which is seen in advanced left ventricular failure, where there is a delayed recovery of some muscle fibers of the weak cardiac muscle, leading to alternation of a big pulse volume and a small pulse volume. And this actually the big one occur when all the cardiac muscle are recovered, and this one when there is a lag on recovery of some muscle fibers. And one of the prerequisites to diagnose pulsus alternans is regular pulse. If you have a patient with atrial fibrillation, you should not comment on pulsus alternans, because the pulse volume is actually variable due to variable filling of the heart cycle due to irregularity caused by atrial fibrillation. Second pulse character that's seen in patients with severe aortic stenosis is slow rising small volume pulse. This actually caused due to obstruction of the flow of blood outside the heart. This is caused by a valvular lesion at the gate of the heart, which is aorta. So this seen in patient with severe aortic stenosis, called the pulsus tardus aberrans. Third abnormality is pulsus bispherians. That means that we have two peaks of pulse during systole. This is actually caused by interruption of systolic flow by obstruction, which might be fixed obstruction, like patient with aortic stenosis, or patient with hypertrophic cardiomyopathy who had dynamic obstruction at the mid systole, when the muscle of the septum meeting the outflow track of the heart. Finally, pulsus paradoxus. Why it is called paradoxus? Because normally during inspiration the pulse volume decrease. This phenomena is normal, but up to certain limits. A drop of blood pressure up to 10 millimeter mercury is normal, but when exaggeration of this normal drop occur, more than 10 millimeter mercury drop of blood pressure during inspiration, this is pathological and might be seen in patient where the filling of the heart is impaired due to compression from outside, like in cardiac tamponade patient, or due to mechanical obstruction in the pulmonary circulation, like in patient with pulmonary embolism. This actually might be hard to pick during just pulse palpation while the patient is taking inspiration. Could be more appreciated using the cuff of blood pressure and recording the systolic blood pressure of the patient, then asking the patient to take deep inspiration and then gradually deflating the cuff and take the record of systolic blood pressure after deep inspiration. If there is a drop more than 10 millimeter mercury, this actually diagnoses pulsus paradoxus. Moving upward to the arm, where we measure blood pressure. The prerequisite or the important aspects of blood pressure measurement is to avoid conditions that could elevate blood pressure or activate the sympathetic nervous system and give a false reading. So the patient should seated comfortably with back supported, arm supported at the level of the heart, pair with not measuring over closes, the leg uncrossed to avoid increase in the afterload of the heart. As we said, the arm at the level of the heart level, and the cup should be of adequate size. That should be at least 80% of the arm circumference. We are talking about the bladder of the cuff, and gradually deflating at a slow rate, 1 to 2 millimeter mercury per second, and then getting the first cortical sound, which is the systolic blood pressure, where the first sound is heard by auscultation of the brachial artery while deflating the cuff, and recording the last sound, which is the fifth for the cortical sound, which is denoting the diastolic blood pressure. With one exception, in patients with hyperdynamic circulation or severe aortic regurg, we might still hearing a pulsation till the degree of 0 on the sphygmomanometer. So at this condition, we take the fourth sound, which is muffling of the heart beats during auscultation instead of disappearance of the beats, which is the fifth sound. As we said before, the patient should be relaxed, no smoking at the previous 30 minutes, because nicotine might cause up to 10 to 15 degree elevation of the blood pressure due to endothelial dysfunction, vasoconstriction, and the activation of sympathetic nervous system. Urine retention is one of the most common causes of pseudo hypertension, because if the patient has marked retention, this might cause high elevation of systolic blood pressure up to 30 or 40 degrees above the normal. So the patient should have his bladder empty before taking a record. We should also take 3 different measurements with a couple of minutes between each other, and taking the average of the last 2 reading for recording of blood pressure. And for the first time, we should record on both hands, and if there is a difference between both hands, we take the higher one. Finally, if we have a patient with suspected orthostatic hypotension, this meaning that the patient complaining of dizziness or some pre-syncope or something like that on standing, this actually seen in patient in old age or diabetic neuropathy patient. We should record blood pressure again after standing for 3 minutes to exclude orthostatic hypotension, which is defined by drop of blood pressure more than 20 in systole or 10 millimeter mercury for diastole. So what is normal? What is normal while standing? Normally, when we stand, the systolic blood pressure drop but less than 20 millimeter mercury, and the diastolic blood pressure either remains the same or become higher. So drop of diastolic blood pressure is pathological. Then moving upward towards head and neck, starting with head examination. Looking around the eye for xanthelasma, which denote hypercholesterolemia. Looking at conjunctiva for pallor, denoting anemia. Jaundice might be seen in hepatic congestion in our cardiac patients. Then moving to mouth, searching for central cyanosis seen in patients with cyanotic heart disease. Ulcers, painless ulcer like systemic lupus patient or painful one in basic patient. Telangiectasia also might be seen in patient with hereditary hemorrhagic telangiectasia, which might be associated with lung fistula. Macroglossia might be seen in patient with amyloidosis, myxedema, or acromegaly. Then finally, the Shexo patient for malar rash that might be seen in patient with rheumatic mitral stenosis, pulmonary hypertension, or systemic lupus erythematosus. Then moving to the neck. A nice piece of information that the giraffe has a valve in their internal jugular vein to prevent drop of the column, this large column of blood, while the giraffe is getting their head downward while eating. So we can't measure the jugular venous pressure on giraffe, but fortunately in human we don't have any valve in this area between the internal jugular vein and the right atrium, so measuring the column of blood in the internal jugular vein might give a data about the volume status or the right atrial pressure. What is the normal right atrial pressure? Normally it is less than 8 centimeter water. So if we know a piece of information that the distance between the mid level of right atrium and sternal angle is about 5 centimeter, so normally the elevation of the column of the blood in the internal jugular vein above this point at the sternal angle should be less than 3 centimeter, because 3 plus 5 is 8 centimeter, which is the upper cutoff point of right atrial pressure. So elevated column of blood in the internal jugular vein while the patient is seated in 45 degree above 3 centimeter is abnormal and denoting marked or more right atrial pressure and volume overload. So how to measure the jugular venous pressure while the patient is seated 45 degree to get the mid level of right atrium at this point from the sternal angle, which is about 5 centimeter, and then taking two ruler, one perpendicular to the sternal angle and one horizontal to the upper level of the seen jugular venous pulsation. Then taking the record. If it is more than 3 centimeters, this is as we said abnormal. And this is the first to comment on jugular venous pressure. Is it elevated or not? A second important point, which is more simple maneuver to measure jugular venous pressure, is getting the patient sitting 90 degree. Then any elevation of jugular venous pressure above the clavicle is abnormal, because at sitting level the distance between the clavicle and the mid right atrial level is 8 centimeter water. So any elevation above the clavicle is denoting elevation of jugular venous pressure more than 8, which is pathological. This is the second more simpler method. So what is the causes of elevated jugular venous pressure or congested neck veins? This is actually divided into pulsating and non-pulsating neck vein. Pulsating meaning that the jugular vein is still connected to the right atrium without any obstruction in this way. This actually is the most common cause. Pulsating neck veins are right side heart failure, impaired filling of the right atrium due to compression from outside by precardial effusion or by constrictive pericarditis. On the other hand, the causes of non-pulsating neck vein is obstruction of the internal jugular venous pressure, internal jugular vein connection with the right atrial. This caused by compression from outside, like in mediastinal syndrome, Bankus tumor, or obstruction inside, like thrombosis of superior vena cava. This actually might be seen in patients with indwelling jugular venous catheter either for central line or dialysis. So the first comment is the jugular venous pressure is elevated or not, and we know how to measure now, and the differential diagnosis of elevated jugular venous pressure. Second point is commenting in the waveform of jugular vein. As we said, jugular vein is a mirror of the pressure inside the right atrium. So we should know what is the normal waveform or normal pressure changes that occur inside the right atrium. Starting at this point, the Y wave, Y for emptying. So the Y wave occur during the filling of right ventricle from the right atrium after the tricuspid valve open, and this account for 70% of filling of the right ventricle. This causes the opening of tricuspid valve and passive filling or emptying of the right atrium into right ventricle, causing this negative deflection on the jugular venous waveform called Y wave. The remaining volume inside the atrium enters the ventricle by force of atrial contraction at late diastole. So the A wave for atrial systole or atrial contraction, which is the most prominent positive wave in the jugular waveform. Then after kicking the last drops of blood inside the right atrium into the right ventricle, the tricuspid valve closes, causing a deflection called C wave. This is not important. Then the atrium starts to relax and the tricuspid annulus become pulled downward by ventricular systole, causing a negative pressure changes inside the right atrium, which is called the X wave. So normally during systole, the neck vein waveform is negative, which is X wave. So can we see this waveform in regular practice? Actually, the eye will appreciate the most positive one and the most negative one, which is the A wave and X wave. How to differentiate these waves? By timing with the carotid pulsation. So if we have a positive wave just before the feeling of carotid pulsation or systole, the positive wave before systole is the A wave, and the negative wave with systole is the X wave. This is the clue for understanding the waveform of jugular venous pressure during examination. We should know two important points in the comment in jugular venous waveform. First one is there is normally systolic collapse of jugular venous waveform, the X wave, due to atrial relaxation and pulling down the tricuspid annulus towards the ventricle or suction effect caused by ventricular systole. So if we have a patient with abnormality like systolic expansion of neck vein, this is abnormal, and the causes of this either incompetence of the tricuspid valve, which is a valve between the atria and the ventricle, causing regurg of blood during this phase and a positive wave here. This causes systolic expansion with tricuspid regurgitation, or the patient has electric abnormalities that lead to absence of atrial contraction and relaxation, which is atrial fibrillation. And this is the most common causes of systolic expansion of neck veins. The second abnormality that might be picked but a little bit difficult is to see augmented positive A wave. And as we said, how we know this is A wave, this is a positive wave just before feeling the pulse of the patient, systolic pulse of the patient. This could be seen in patient who has pressure overload over the atrium or the right atrium of the heart, as in patient with obstruction in the tricuspid valve, tricuspid stenosis at the pulmonary level, pulmonary stenosis, or raised pressure in the pulmonary circulation, pulmonary hypertension. This is the causes of giant A waves. And finally, the abnormality that could be seen is deep Y descent. Normally, as we said, we appreciate only the most positive wave, which is A wave, and the most negative wave, which is X wave. But if we see double negative waves, which is X and Y become deep and seen as well as the X wave. This occurs in patient with constrictive pericarditis. What is the cause of deep Y descent? Because this patient has limited filling of the right ventricle during the very early period of diastole, as after this point the ventricle can't receive blood due to mechanical obstruction or compression from outside by the tough pericardium. So it acclimatizes with this by early rapid filling between atria and ventricle, causing a deep Y descent. And finally, the final thing that we should comment after we comment on the waveform is asking the patient to take deep inspiration. What is normally occur during deep inspiration? This creates a negative intrathoracic pressure that causes suction of any blood inside the jugular veins into the right atrium. So what is abnormal is inspiratory expansion of the neck veins. When you asking the patient to take inspiration, then you see this sign. This is called Cosmal sign, or systolic expansion, or inspiratory expansion of the neck vein. This actually occurs in patients who have limited receiving capacity of the right side of the heart due to mechanical compression, like in patients with tamponade, constrictive pericarditis, or obstruction inside the pulmonary circulation in pulmonary embolism. These are the causes of inspiratory expansion of the neck veins. So to summarize what we said, first thing is looking at the jugular venous pressure at 45 degree. If it is elevated more than 3 centimeters, then we called it raised jugular venous pressure. And the second thing is commenting in the waveform. The most important thing is the patient has systolic collapse or systolic expansion. If he has abnormal systolic expansion of the neck vein, this might be caused by tricuspid regurgitation or atrial fibrillation. And the third comment is after asking the patient to take deep inspiration, is there is inspiratory collapse which is normal, or if the patient has inspiratory expansion of neck veins, which is called Cosmal sign, that occur in patients with constrictive pericarditis, tamponade, or pulmonary embolism. Then moving to other structure in the neck, after assessing jugular venous pressure, assessing the carotid pulsation using the thumb of the hand. The abnormality that could be picked at the carotid pulse is getting a thrill or tickling sensation in your finger. This is called by obstruction inside the carotid itself, as in patient with carotid stenosis, or might be transmitted from obstruction at the gateway of the heart, which is aortic valve, caused by aortic stenosis. We should also, we might also find a prominent or strong carotid pulsation that might be seen without even palpating the pulse. This is called Corrigan sign, which is seen in patients who have severe aortic regurgitation. Another sign of severe aortic regurgitation is Demosay sign, which is nodding of the head during with each heart pulsation, due to also high volume output caused by severe aortic regurgitation. The last thing is commenting on any thyroid swelling or lymph node. Then moving downwards towards the leg, first thing is palpating dorsalis pedis, anterior tibial artery, posterior tibial artery, and popliteal femoral arteries. Dorsalis pedis might be not felt in about 15 to 20% of patient, but we should then assess the anterior tibial artery. If the anterior tibial artery is felt, this is okay. If not felt, this is might be pathological. Then assessing the presence of any edema by pressing over a bone prominence like chain of tibia for 10 seconds. If we have a bedding edema, which is the most common type of edema in cardiac patient, this denotes volume overload. The presence of lower limb edema denotes at least 4 to 5 liter of volume overload in the patient. Other causes of bedding edema is due to low oncotic pressure caused by hypoalbuminemia. The extremely rare finding is non-bedding edema, which is usually caused by lymphedema. The other thing to assess is for scars in the lower limb that caused by harvesting the saphenous vein used in cardiac bypass surgery or CABG surgery. This might give a clue if we have a patient who gave a history of open heart and he didn't recall the type of surgery. Is it valve surgery or CABG surgery? The finding of this scar gave a clue that this patient has a CABG operation. And then moving upward towards the abdomen, the most important couple of things on abdominal examination is palpation for hepatomegaly and percussion for ascites. The cardiac causes of hepatomegaly or ascites are mainly related to raised right-sided pressure caused by right-side heart failure, tricuspid regurgitation or stenosis, and pericardial disease. And here is an important clinical point. If the patient gives the sequence of marked abdominal distension followed by lower limb edema, this is called ascites precox. That means ascites occur before lower limb edema. This is a little bit pathognomonic for pericardial disease or tricuspid stenosis. Then moving to the back of the chest for auscultation of diminished air entry that might be seen in effusion, crackles caused by fluid inside the alveolar space caused by congestion. And there is an important point to differentiate between crackle caused by congestion and that caused by fibrosis. Crackles caused by congestion are early and mid-inspiratory crackles, because the fluid is already inside the alveoli and the air entering with inspiration causing this crackles from the first scratch of inspiration process. But in patient with fibrosis, the crepitation sound is heard when the tensile capacity of alveoli is reached at the end of inspiration, which is late inspiratory 1. The third abnormality that might be heard is bubbling crepitation, denoting marked volume inside the alveoli in patient with pulmonary edema. And last thing is cardiac asthma or wheezes. This important thing that you should put in your differential diagnosis when hearing a widespread wheezes across the chest, that congestion of the airway might cause also wheezes, like that of bronchial asthma or airway disease patient. So the presence of wheezes does not mean 100% that this patient has only a chest disease. This also could be heard in patient with heart failure. And finally, the presence of bronchial breathing in patient with a complication like pneumonia, abscess, or pulmonary infarction. Then moving toward this local cardiac examination.